Thank you to Frank for the invitation. So I'm not going to need financial disclosures, but I did contribute evidence on the number of stakeholders during the consultation period. So what are we talking about? Well, we're talking about one of a series of advisory publications from NICE, this time looking at treatment of aneurysms, came out in the summer of last year. And there was some much sensible contemporary advice about how to treat aneurysms within this publication, but there were 4 or 5 very contentious recommendations, not least that no elective patient should have EVAR. Also that complex EVAR should only be performed within an RCT, even though the UK had looked at this and come up with the conclusion that that wasn't possible. That any patients unfit for open surgery should have no intervention at all, and that EVAR should be used in emergency cases, even though we were going to lose some of our practice electively. Therefore, we'd have to use it in the most difficult scenario. And finally, just as we were getting some evidence about the concerns about radiation and cancer, that all surveillance should be by CT. Well, we now have a consultation period finished. There was unprecedented feedback. Publication deadlines have come and gone. The committee was actually discharged in July, and we still don't have a publication date. Having said that, for all the comic and sometimes not so comic criticism, Andrew, on the last panel, all members actually chose open surgery. And if you look at the UK NVR data, we've already seen a shift away from EVAR to some extent. Now, whether the background was the RCTs or whether it was people in their own MDTs seeing some poor outcomes late on, I'm not so sure. So why is this unfair? Well, the NICE rules can only consider RCT evidence, and they look at cost effectiveness because they have financial responsibility to other patients. So they're unable to consider some of the contemporary data. They didn't look at IFU because they assumed all patients were within IFU in the trials, that there wasn't a definition of fitness, and they felt they only had to look at complex EVAR and open surgery within an RCT because they only consider RCTs. I think there was some bias here. If you look at the narrative, they said EVAR had higher net costs, and the evidence shows that even if long-term benefits were achievable, they could not plausibly be sufficient to outweigh these costs. So my main point is the anatomy, because we now know from multiple publications that hostile anatomy does badly, that outside IFU patients do worse, that conical necks are bad, that wide necks are bad, and the latest great evidence suggests any neck with a diameter of over 25 millimeters has poor outcomes. And that's because of concerns about dilatation, and when the aorta outgrows the stent graft, the proximal seal is lost. And we've seen this in a number of publications. My point is IFU probably should be measured actually post-op, not pre-op, because it's very easy to measure a neck on a big magged-up screen. Do we actually achieve that seal zone? Should we look at post-implantation IFU? And patient views have already been talked about. Patients seem to prioritize, as Nick Cheshire said earlier, early recovery, and they don't think about what's going to happen in 15 years' time. And I don't think these two groups can be compared properly in an RCT. You can do a 4-vessel fenestrated device for actually a no-neck infrarenal aneurysm. So why is it unfair? Well, the cost analysis in this population is difficult. I don't think all EVAR is equal, and I think patients' priorities differ. I think the assessment of fitness is variable, not binary, and this does not equal longevity. I think a trial, an RCT for complex EVAR is probably unworkable. So in summary, there is a point in some of the recommendations from NICE, but I think a blanket ban on all EVAR is wrong because there's no consideration of anatomy, no consideration of IFU, no allowance for recent data, and I think an RCT for complex EVAR is not really feasible. But crucially, the most important point, even though if we think EVAR is not the finished article at the moment, If we banned it, it would stifle ongoing research to make it better. Thank you.